Good morning, everyone. Can I just get a thumbs up from folks online if you can hear and see us okay? Is there someone there that can? Yep, great. Thank you. All right, welcome. Thank you for joining us either online or in person. It's really nice to see you all here today. My name's Scott Drummond and I'm the Program Manager at VADA, and it's my pleasure to welcome you, and then I'll bow out and hand over to a number of MCs and of course our speakers whom you're here to listen to. May I start by acknowledging country and acknowledging the traditional owners of the land on which we meet today, the Wurundjeri, Woiwurrung and Bunurong peoples of the Kulin Nation, and pay my respects to Aboriginal culture and elders past and present, and acknowledge that those who are joining us online are from different lands, and pay our respects to those lands too and people joining us online. I'd also like to acknowledge those with lived and living experience and celebrate people, family and supporters who have a lived experience of alcohol, medication and other drug use. We value your courage, wisdom and experience. And if I can go just slightly off script, I was in Ballarat earlier this week at an Grampians Regional Interagency Network meeting. And one of the things that we acknowledged there and the table that I was on, and hello to Brendan if you're online joining us today, and that was the learning and experience we can take from our clients or our patients, and how rich that is too. So I just wanted to acknowledge lived and living experience and what we as clinicians and staff can learn from those that we're working with. Thank you to Indivior for sponsoring today's events. Thanks, Susanna, again. We really appreciate your contribution to this forum and supporting us to make it happen. Okay, so this is our third in-person toolkit top-up, and it's actually become, I think, a bit of a fixture. And we struggled with putting this on during COVID, but since that time, we've actually put on one of these each year, and they've been really successful and really popular. I think one of the reasons they're popular is that we listen to and we try and ask our emergency department clinical liaison addiction network nurses, our non-residential withdrawal nurses and others, what would you like? If we're doing another toolkit top-up, what would you like to see and hear? And this informs the development of our program, our toolkit top-up. And we've got a really diverse and interesting set of presentations today. An introduction to inhalants and volatile substances with Dr. Rose Crossin. Thanks, Rose, for joining us. Setting up a nurse-led model of care with Dr. Jackie Richmond. The toxicology of ketamine with Dr. Zef Koutsagianis. Zef, I've chatted with you this morning already. Thank you for joining us. Pain and culture with Monitor Masiti Muta. And pharmacotherapy, a consumer perspective with Sarah Lord, who'll be known to many of you. Today's sessions will also be live streamed and recorded via Zoom, as you can tell, and a link to the recording will be available after the session. Just briefly, for those that are in the room, I think you've seen where morning tea is now, and I hope you've helped yourself to morning tea. Lunch will be there also. Toilets are out the door and to the right. And I wasn't the only one to make this mistake. I assumed the toilet doors were sliding doors. They're not. You push them, in fact. So I stood out. Anyway, you push them, don't wait for them to open. All right. I'm going to hand over to James Petty, my colleague, who will be emceeing our first session for the day. So great to see you all. I hope you enjoy the day, and I'll catch up with you later in the day. Over to you, James.
Thank you, Scott, and thank you for the toilet advice. Always reliable. So I'm James Petty. I'm a project officer at VADA. Thank you for joining us today, and to those online. Pardon me. Our first speaker today is Dr. Rose Crossin, who is a former colleague and a good friend of mine, and it's very nice to see her. We're particularly grateful to Rose because she's literally joining us on her holiday. So it's very generous for you to be here, and thank you very much. Yeah. We're going out for dinner later. So the topic is an introduction to inhalants and volatile substances. Rose is going to explore the differences between those things and some definitional controversy, I suppose, that we were chatting about in the week before this. So Rose is a senior lecturer at the Department of Population Health at the University of Otago, Christchurch campus. She completed her PhD at the University of Melbourne with a thesis on the health impacts of adolescent inhalant misuse. So that's glue and petrol sniffing. And from there worked at Monash University and Penington Institute doing population health research on drugs and alcohol along with drug policy advocacy. She returned to New Zealand in 2020 to take up a position at the University of Otago. Her research is focused on understanding and preventing harms arising from drug use and how we can use harm data to better inform drug policy. She's also an advocate for evidence-based drug policy and is focused on health, well-being and equity. Thank you to Rose.
Okay, I would like to begin by paying my respects to the Wurundjeri people, and I pay my respect to their elders, past, present and emerging. I would also like to pay my respects to the tangata whenua of Aotearoa, which is the land on which I live and work. I'd also like to take a moment to reflect on how sad we all felt from New Zealand seeing your referendum result, coming from a country where we have a treaty and it's really awesome. So yeah, I was sorry and sad, and I sit with that. So cool. So as James kindly mentioned, I am going to do a little bit of an introduction today about volatile solvent misuse. So I did my PhD on this topic. It remains something that I am curious about and interested in, and I think it's a really underexplored issue. So my PhD was both preclinical and clinical and epidemiological in nature, and then I have pivoted to working in public health, which is what I do now in New Zealand. So I hope that I'm going to cover some kind of key facts about inhalants. I'll tell you where we know things and where we don't know very much, and then I'm hoping to have quite a bit of time for questions. So to start with, as James signposted, we need to make sure that we're talking about the same thing, right? When we use the word inhalants, because it is a little bit of a catch-all, and it's a catch-all that I personally feel quite uncomfortable with because it's grouping together a whole bunch of drugs simply by their route of administration. It would be like calling things injectables and assuming then that their pharmacology and epidemiology and pharmacokinetics are the same. They're not. So when we use the blanket word inhalants, we're actually talking about three different types of drugs. We're talking about the volatile solvents, so glue and petrol and a whole bunch of different household products that can be inhaled, rexing. It is called, sometimes you'll hear it called huffing or sniffing or chroming or bagging or rexing. Those all are usually applying to the volatile solvents. However, we also have nitrous oxide, which is grouped in with this class. So nangs, whippets, laughing gas. In terms of the pharmacology, they are quite different drugs, though they have similar demographics in terms of being drugs relatively of younger age groups. So somewhat similar in populations, but different pharmaco effects. And then we have another group of drugs, the alkyl nitrites, that are also sometimes called inhalants and lumped in together, aka poppers or amyl. They're really different, right? Very different modes of effect, again, reasons for use and populations using them. So today, I'm not going to talk about nitrous because I understand that you had a recent session online on nitrous. So cool. So I'm not going to talk about nitrous, and I'm not going to talk about alkyl nitrites. I'm going to focus on volatile solvents because it is a drug class all of its own and worthy of exploration. So hope that's all good. I made sure my scope was okay before I came. In terms of legalities, it is not a banned, so the volatile solvents are not a banned drug. The legislation is set by state and territory. In Victoria, which I assume where most of you are from, it's actually the sale of volatile solvents that's illegal if the person knows or reasonably ought to know, or has cause to believe that someone will inhale the substance. That's pretty loose, right? So, I'm not aware that anyone has ever been prosecuted for selling, selling paint cans or glue to someone who then went on and inhaled it. Then retailers are kind of putting their own level over that, so that it actually is illegal to sell to anyone if they reasonably ought to know that they're going to inhale. This isn't an under 18, over 18 rule, but you'll see lots of retailers then putting an age limit on it as a way of trying to enact and enforce this policy. But even if someone was 30 and was buying a solvent and they ought to have reasonably known that they were going to inhale it, it would still be illegal for that person to be sold to. But there are no criminal penalties for possession. It's not covered under any kind of drug law or drug legislation. And I've put a link to the bottom for at least the Victorian legislative framework for you. The common ingredient, the bit that gets you high, is toluene. So it is a volatile liquid, so it's a vapor at room temperature. It's an aromatic hydrocarbon, VAR. It's water insoluble and colorless and has a really, really sweet, strong smell. So it is, you would recognize it. It's, the smell that's in marker pens and solvents and glue. It's that, you'd recognize it if we had some here. There's also benzene or xylene, which are also volatile solvents, but toluene is the main drug that we worry about, and the main drug that has pharmacological effects. So in preclinical models, so in animal studies of drug misuse and addiction, they actually use toluene in isolation by itself rather than all of the other products that are used. So toluene is the active part of these drugs, for want of a better word. So we're not talking about workplace exposure here, right? Because people can. So if you worked in a chemical factory, you could be exposed to toluene in a workplace setting. But in that instance, it would be at relatively low concentration, so in the hundreds of parts per million, and it would be a relatively constant exposure. That's not what we're talking about. We are talking about the deliberate inhalation of these products to create an altered mental state. So sometimes people will inhale them directly from the container, or they'll spray or soak a cloth and then inhale from that over the face. So that would be called huffing. Or you could spray or pour it into a plastic bag and then inhale from that, which people will call bagging. And the concentrations of toluene, when they're used in this way, are substantially higher than workplace exposure. So the concentrations will range from about 3,000 to 15,000 parts per million. So it's really quite strong and intense for toluene. So toluene in itself is a CNS depressant, a central nervous system depressant. After someone inhales it, it moves really rapidly across the lungs into the bloodstream and is equally rapidly metabolized. So it's primarily excreted as urinary hippuric acid, but people who use this drug chronically can have accumulation in the lipid-rich organs. So accumulation can occur in the brain, the adipose tissue, the kidneys, the adrenal glands, if people are using long-term. And because of these pharmacokinetics and the fact that it comes in really quickly and out really quite quickly, there are no established blood, saliva, or urine tests for this type of drug. So any data that we have is based on self-report and clues that someone is using this drug. You cannot confirm it with any form of testing. The effects are really rapid, so it is a fast drug. The effects will occur within minutes, and it has an inverted U-shaped curve for concentration and effect. So at the very early stages, it is an excitatory drug. People will experience locomotor stimulation, feelings of euphoria and exhilaration. Then as the concentrations increase, then CNS depression starts to come in, and people will experience slurring and weakness and disorientation, and then move through as the concentrations continue into sedation. People can experience cardiopulmonary failure, or sudden sniffing death, which, so at an immediate cessation or depression of the respiratory system, and then tragically die from using these drugs. So the typical population of people who use volatile solvents are young people, particularly really young people. So often it's that 10 to 14-year-old age group, maybe 10 to 15. So it's the younger age group. It's one of the few drugs where people tend to age out of it. So if you look at survey data of secondary students, the use decreases the older people get. It is also associated with vulnerable and marginalised youth and youth in protective juvenile justice or protective services. And it's associated as well with other vulnerable or marginalised populations. So people who are homeless, people who it is associated with Aboriginal and Torres Strait Islander populations, particularly in the remote communities. It is a drug that is quite heavily associated with socioeconomic disadvantage and vulnerability. And there's a couple of reasons for that it's hypothesized to be simply because it's an easy drug to get hold of, right? There are probably 10 things in this room that could get us high if we so desired. It's easy to get, it's low cost, and it's legal, right? So there are a whole bunch of drivers for people to use this drug. There are a range of potential harms that can arise, and I've broken this down into acute and chronic harms, and it's a little bit of a list, but I've also put a link to an article that has a very good updated review of its effects. So acutely, the harms can be people can experience quite a nasty headache from using these drugs. They can get burns and frostbite, particularly if they're using a pressurized vessel and inhaling directly from it, so that you can get coolant burns and frostbite from it. People can experience blackouts. They can become quite agitated and experience hallucination or psychosis symptoms. It is associated with both intentional and non-intentional injuries. It has quite a strong association with self-injury and suicidal behaviour, particularly in people who use this drug chronically, which is going to be this kind of complex interplay between vulnerability and the effects of the drug and the population who are using it. People can experience suffocation or asphyxia, particularly if they're bagging and if they're using a plastic bag and putting it completely over their face. And people can also experience sudden sniffing death, so cardiac failure can occur. And this isn't a chronic use issue, so people can, after only 1 or 2 times using this drug, there's no kind of dose effect. There is a dose effect, but not because of using multiple times, that you could use it for the first time and experience sudden sniffing death. Those who use this drug tend to use it though, there's kind of an experimental group, the ones who will use it once or twice and then move on. But people who tend to go on and use this drug will do so chronically and use it for quite heavily over long periods of time. And there are a whole bunch of harms that can arise from chronic use as well. It is very neurotoxic. It can have cognitive impairments on learning and memory due to structural brain changes. Those are reversible, but it takes quite a long time for recovery. People can experience anemia because it impacts the white blood cells, a really persistent cough or shortness of breath, tremors or ataxia, changes to mood and mental health, a quite substantially increased risk of suicidal thoughts or behaviours, dependence, appetite suppression, and growth impairment, so low body weight as well as vertical height growth impairment, which, given that we know that it's associated in that kind of early adolescent years, any impacts on growth. Oh, is that me? So am I? Okay, good. I thought I'd bumped my thing. So yeah, any impacts on growth can have quite a long-standing impact. Because of it being in this in a peak growth period for young people. So I was asked to, when the scope was being put together for me on this, I was asked to cover the prevalence of use. And this is where now you're going to start to hear me say things like, for the best that we know that, or we're pretty sure that, or because our data gets really shaky around this point. Part of the reason the data gets really shaky is because, as I mentioned, they all get lumped together as inhalants. So the National Drug Strategy Household Survey, for instance, does ask people about their use of inhalants, but the main part of the question includes volatile solvents, nitrous and alkyl nitrites. So in 2019, 1.4% of those aged 14 and over report past year use of inhalants, and this trend is slightly increasing. It's that, from a relatively low baseline. But if you have a look at the table at the bottom there, you can see that that is almost all nitrous and alkyl nitrites. So in 2019, of those people who recently, which is, I think they define recent as past year use of inhalants, for instance, 63% of that were people nominating nitrous. So when you're thinking about looking for survey data, be really cautious if they don't break it down by type, because they might not be talking about volatile solvents at all. But this is an adult survey, right? People aged 14 and over. Whereas we know that use is most prevalent in younger populations. So we should and do use the Australian Secondary School Alcohol and Drug Survey, ASAD. Again, though, their definition of inhalants includes volatile solvents, nitrous and alkyl nitrites combined. And they don't separate, like the previous table then broke it down by type. ASAD doesn't. So it gets really tricky at that point to know what's happening. Inhalants and cannabis are the two most commonly reported illicit drugs used by those aged 12 to 17. And I use the word illicit loosely. That's their wording, but as we know, it's not illegal to use. Use decreases with increasing age. And in 2017, 13% of people aged 12 to 17 report past year use. And that has slightly increased from 2011. It is showing an increasing trend. But again, as I said, not separated by type. So compare and contrast that to the adults, right? Even if we just look at that blanket grouping of inhalants, we're going from 1.4% to 13%. So you can see it is quite concentrated in that age group. There are a whole bunch of use measurement challenges with this drug. I personally think this is going to be a substantial undercount, and there's a couple of reasons for that. One is that the age group issue. So the Australian Secondary School Survey starts at age 12, and the prevalence of use at that point is over 10%. You can't tell me that people go from no use at age 10, no use at age 11, and then suddenly we get 10% use at age 12, right? That doesn't make any sense. But no one asks 10 and 11-year-olds. There is no survey that covers that age group. So I think we've got an undercount because of the age group. I think we've got an undercount because these are household and school surveys. And if we're talking about vulnerable and marginalised youth, they're not going to be the type who are going to be doing the survey in secondary school. It's even the household survey relies on having a house, right? So I suspect we are grossly undercounting volatile solvent misuse. And as I said, there is then a problem with, even if they ask about inhalants, which ones are they actually asking about? It is really careful if you're trying to use and interpret this data to go carefully into the code book of the survey and check the definitions to work out what they're actually asking about, because it may not be volatile solvents at all. So I feel like I spend half my working career banging on about use is not equivalent with harm, right? And I'm sure you guys are all going to agree with me. So we measure use far more frequently than we measure harm. We kind of use them as a proxy. But we would try and argue that we would do better to actually measure harm. So what is the prevalence of harm? So there are three studies that I'd like to draw your attention to, which are the three sort of most recent and have a decent kind of coverage of harm data. The first of which is a study published fairly recently in 2023 in clinical toxicology led by Shane Dark. And in Australia from 2000 to 2021, there were 164 deaths due to volatile solvent misuse, predominantly males with a median age of 26, and most of those deaths were due to unintentional toxicity or unintentional asphyxia. So a 20-year period, but still not an insignificant number. The second study was also published this year, and it looked at poisons information calls, which, as a proxy of harm, I think is quite useful. Someone is worried, at least, right? For someone to make that phone call, either the person or their relative is worried. There were, in the last 10 years, or 2010 to 2020, there were 752 calls made to the New South Wales only Poisons Info Centre, predominantly relating to children and adolescents inhaling. And that trend has been increasing since 2017, so suggestive of increasing harm. And then a study that I led back in 2018, which looked at ambulance attendances from 2012 to 2017 in Victoria. There were 779 ambulance attendances related to volatile solvent use. They were often concurrent with suicidal behaviour or mental health issues. So these were not necessarily calling an ambulance because they were acutely unwell from the effects of inhalants, though they sometimes were, but they had been using inhalants, they were acutely affected, and then were experiencing mental health or suicidal thoughts or behaviours, and that was the reason that the ambulance had been called. So there is evidence of harm from these drugs, and I think that this harm data is probably a better indicator of what's happening at a population level than the use data, personally. So, warning signs, I suppose, given that we've got no toxicological or kind of clinical way of finding out if someone has been using this drug or not, there are a few warning signs that can be communicated to families or to parents or to watch out for. One is a kind of that chemical smell, that sweet, strong toluene smell on breath or clothes, or people, particularly if they are inhaling spray cans, may have stains on their face, hands, or clothes. Families often report empty or hidden containers, and there was a relatively well-publicised coronial case fairly recently that was highlighted in the coronial report, that parents had actually seen these empty containers but didn't realise what they meant. Another thing to watch out for is a loss of appetite or very rapid weight loss. It is a very, very strong appetite suppressant, to the extent that there have been reports that some young people actually use it for that purpose, to try and lose weight. And yeah, it is very strong as an appetite suppressant. Behavioural changes, particularly apathy, an acute sort of slurring or lack of coordination or ataxia, and also skin irritation, like those blisters or ulcers or frostbite particularly around the nose or mouth, are sort of warning flags of this behaviour. DSM-5 actually has an inhalant use disorder. It is hard to define. It is based on both symptoms of withdrawal, which could be headache, nausea, and tiredness, and frequency of use. So they're looking for developing tolerance or presence of withdrawal symptoms. But there is a kind of a disorder identified. People can become dependent on toluene. It has addictive potential, so people can become chronically dependent and then experience withdrawal symptoms. Treatment-wise, here we get into some really big unknowns. There is very unclear evidence of efficacy for most treatment modalities, at least from a research kind of evidence perspective. There is potential for family therapy and activity-based programs and some culturally appropriate residential approaches. most people who are experiencing harm from volatile solvents are either going to get outpatient counselling or residential rehab. There is no specific pharmacotherapy for it. Evidence at this point is pretty light on, unfortunately. Given that the treatment options are not particularly great, I think it is really important to consider, if you're working with a young person who uses these drugs, is to provide them with accurate harm reduction advice. So we have some really good harm reduction advice. It is somewhat generic, like particularly avoiding mixing with other drugs. So particularly the other depressants like alcohol, benzos, or opioids. Avoid using alone in case you experience harm. Avoid use in confined spaces because of the potential for the concentration to build up in that room or area. Avoid using near open flames or cigarettes. Many of these products are exceedingly flammable and in pressurized containers, so very high risk there. And to try and use methods that stop the product from directly touching the skin, the mouth, or the nose. So trying to use in a way that has that some degree of separation between the product and people's skin, because of the potential for quite nasty skin effects. But so I feel like I'm not presenting you with a very happy picture here in terms of, we don't know an awful lot. We don't have very good treatment efficacy. We know that it's a really vulnerable group that are using these drugs. So I'll bring it back to public health, which is what I do. So we can and do have regulation to try and restrict supply of these drugs, but you can't, I mean, well, supply reduction. When does supply reduction ever work? Hey, James, very rarely. And these products are everywhere. They're common household products. It's not like we're going to get rid of them. There have been efforts made over the years at product modification and reformulation with some degree of success to stop things from being so easy to inhale. I think the best evidence, though, is for community-led demand reduction programs and working with communities to try and reduce demand for these drugs. And I bring it back to the really amazing and groundbreaking work by Sarah McLean, who was an absolute forerunner and a giant in this space, that she would say that inhalant misuse isn't really a drug issue. It's actually a comorbidity and a marker of global vulnerability. And so I would like to leave you with this quote, because I really think that this just sums everything up, that ultimately the most effective interventions into volatile substance misuse are likely to be those activities that redress social and economic disadvantage and enhance the opportunities, capacities, and confidence of young people. I think everything else that we do is just going to be putting a band-aid on it. I've put links to articles at the bottom of these slides, which I understand you'll be getting a copy of. But just to give you a few other resources. So Poisons Information Centre, great for if you need advice with a young person immediately. I think Alcohol and Drug Foundation's website and page there is really good and a good resource. And this is Volatile Substance Misuse, a Review of Interventions. Is old. It is an old piece of work. So I think it was 2006, but Sarah McLean and Peter Darbs wrote this. There hasn't been, it is old, but it is exceedingly thorough, and it is probably the best piece of evidence that we've got for how to respond to volatile solvent use. So that's the direction that I would point you in. Thank you.
Thanks, Rose. Very interesting presentation. And yeah, I hadn't heard that term global vulnerability before, but it certainly does seem like a kind of, especially that kind of chronic use, it's going to be caused by other or associated with other kind of vulnerabilities, and there's that grimness about it that it's a bit desperate.
Yeah.
Anyway, that's just my reflection. We do have some roving mics, so if anyone has questions for Rose, we have plenty of time, so please ask away.
Hey, Rose.
Hey.
Is there any research that suggests that younger cohort are replacing huffing solvents with another illicit drug?
I don't know that it is I don't think it's a replacement at an individual level per se. What the research evidence suggests is that the volatile solvents have gone out of favour amongst a younger age group in favour of nitrous more generally. But what we don't know is are they just two different populations, right? And I have my hypothesis is that they probably are, that the people who use, because you still have to buy nangs, right? And they are used more in that party type context. So in the population level data, we do see volatile solvents going down and nitrous coming up in the same age group, but I don't think that that is a replacement effect in individuals. My hypothesis would be that we've still got a very significant group of people who are using volatile solvents, and we're not seeing them in the data. But I think they are very much still there. But yeah, the evidence, I'm not aware of any study that has done that has basically followed the same young people or had a kind of cohort or repeated measures effect to look at transitions between those drugs, unfortunately. Hi.
Yeah, hi. I mean, some of the warning signs that you identified, I'm interested to know if there's any research or data on the link between youth graffiti and these inhalants, because most of those warning signs could also indicate graffiti, right?
Yeah, they could. I am not aware of any, unfortunately. I wouldn't even like to hypothesize. I think whether or not there's some overlap between those kind of subcultural groups of people who use inhalants and people who are graffitiing, I honestly don't know, and I've never seen that.
New research project, perhaps.
I know, right? My life is just one big list of research I would like to do, and yeah, but no, I think that's a really important point. I guess, if I am a parent of a 10 and a 12-year-old, I think those warning signs, if I saw those warning signs, it's not like I'm going to go in there all guns blazing and be like, are you sniffing? But I think it would be a prompt for questions to be asked. And the answer to those questions, assuming you get an answer from a 12 or 14-year-old, might be not that they're inhaling it, but that they're graffitiing. But I think they would prompt me to ask questions. Yeah.
Hi, Eleanor has asked in the chat, is there a chance that the younger cohort could be using it for weight loss?
Yes, I think so. The data is, at that point, we get really sketchy. We get down into kind of clinical case studies. There are so the places that we get data from on this are a couple of clinical case studies where young people, particularly young women, have said in there that was the reason they were using it, is to lose weight. We also have data. I focused on Victoria because that's where and Australia because that's where we are. But these drugs are really common in developing countries. So in particular, Mexico and India, for example, have really high rates of volatile solvent misuse. And there has been, there is a stronger body of evidence that suggests that people are actively using these drugs because it staves off hunger pains. It stops you from feeling hungry. I want to say at a personal level, it's somewhat of a legitimate response, right? Like it stops you from feeling hungry when you're hungry. So yes, there is evidence to suggest that young people are using it, certainly for appetite suppression, and mixed evidence for weight loss, but it is quite profound weight loss. So it works. I couldn't think of a better word. But yes, it does. Hi.
Hi, I've seen in the hospital setting some really significant cases of Nang abuse and its effect on the neurological system.
Yep.
Like one guy who basically could not walk
Yeah.
when he came into hospital. Do you get the same sort of effects with volatiles abuse?
So there it is associated with ataxia, but for different reasons. So with NANGs, it's the demyelination of the central nervous system, which is caused by chronic, I think it's B12, isn't it? Big chronic B12, because it stops the absorption of B12, which is why you get those really strong neurological effects from nitrous. With volatile solvents, it's more of a central nervous system effect. So people do present with quite severe ataxia and a lack of coordination. The best data we have on this comes from the Northern Territory from a study that began in 95, and they followed a cohort of young people who were chronic users of petrol for sniffing through 3 data points before and after a really big community-led intervention program. And they found that those neurological symptoms and those ataxia symptoms generally resolved, but it did take quite a long time. So I think it was well over 5 years after people became abstinent and stopped using this drug that those central nervous system ataxia symptoms went away.
Mm.
Hello. Yeah, with the proliferation of using this volatile substances in the young cohort, do you think it's like a peer driven behavior?
Yes, I think to be honest, for all substance and drug use in young people, I suspect it's going to be a peer, a peer initiated or peer effect. One thing that I think is really important to note about these drugs come in waves, right? Drugs go in and out of fashion. So during the 90s, we were at peak volatile solvent misuse and really, really high rates. And then it came back down and had a downward wave again. So the best data we have on this now comes from the US, from their Monitoring the Future study, and they are seeing, so they saw that big peak, it came down, and they are now having quite a substantial increase again, but a pre-marker of the increase, so before use started increasing again in young people, for the 2 survey waves before that, young people started not endorsing the idea that it was risky. So they asked questions about use, but they also asked questions in Monitoring the Future about perceived risks. And what they saw was that before that young people weren't seeing it as a risky drug, and then use followed it a couple of years, a couple of data waves later. And I would hypothesize, which is a scientific word for guess, that what I reckon has happened is that it was basically just a generational effect. Like there was a whole bunch of kind of education and comms and public health and intervention measures in that peak period in the 90s. And then we've got a cohort of young people who just missed it, who missed that entirely. And we've gone through a gap where there's been nothing because there wasn't much misuse, or misuse rates were going down, and because they're not getting those resources and it's not really on the public consciousness, then they're not perceiving it as a risk, thus they use. That's my working guess.
We have another online question.
This is from Eleanor again. She said, could thiamine help with harm minimization related to B12 deficiency?
For nitrous? Yes, absolutely. Yep. So that's in relation to NANG use. Yes, it is one of the harm reduction measures that is suggested for people is to take supplements for sure.
Thanks, Rose. May I ask you and clinicians online or in the room about management of withdrawal from volatile substances?
I am not aware that there's any standardized pharmacotherapy or standardized treatment. The there is a service. I don't know, is there anyone here from Queensland? This is just Victorian Forum, isn't it? Okay. So there is an inpatient service in Queensland that certainly when I was doing my PhD, used to have a fairly, at least 5 or 6 young people coming in a year that were predominantly dependent on volatile solvents. I don't think that they had anything tailored to that drug, but yeah, I think I'm not aware of anything. Yeah.
Any clinicians want to jump?
Yeah, please. Oh, no.
Okay. Ask a question.
Yeah, I do have a question.
Yeah, please.
Do you have any examples of the brand modifications?
Yeah, so the one I was particularly thinking of was Opal Fuel. So when they tried to have, which was in the sort of the peak of the petrol sniffing kind of problems, that the Opal Fuel reformulation was at least temporarily relatively effective, but it came alongside a whole bunch of other community-led interventions that were more focused on demand reduction. So yeah, that was what I was particularly thinking of. But the review, I think there might be a few other examples in the literature from particularly related to commercial products to make them a little bit less easy to inhale. But I'm pretty sure that there's a section in that review that I pointed to. I can't think of those off the top of my head, but the review on the previous, that volatile substance misuse review of interventions will have at least up until 2006, the summary of evidence. And I'm not aware of anything that's been done since then. It kind of just dropped off of the policy and public consciousness around that point in time. And when that happens, then the research plummets pretty much. So yeah, no. Yeah.
I have a quick question. Does petrol contain toluene, or is it a?
Does.
It
Yeah.
does.
Yeah. As well as benzene.
Yeah, right.
Things. Yeah.
Okay.
But when petrol in the bad old days, when of the really peak petrol sniffing problem, it also had lead in it. So then the issues that were occurring for people were a combination of toluene, benzene, and lead.
Lead poisoning.
Yeah. Mm-hmm. Which have similar kind of neurological impacts. So it was a problem. An additive problem.
Any other questions? Any more? None online? Yeah, Tom.
Hi. Are you aware of anyone or any research, or case studies on acetone use?
Ooh. I can't think of anything off the top of my head. I had Google Scholar in front of me. I certainly can't picture anything. It is inhaled and can be used in this way. There might be something out there, but I am not particular. Yeah, I can't think of anything. Sorry.
Okay, thanks.
Is that a question up there? No.
Oh, stretchy question.
Yeah. Hi, I'm just wondering, in terms of you were talking before about the neurological damage and stuff, and someone mentioned something about thiamine would be potentially a treatment for it. Why would you not go hydroxycobalamin instead?
So this is just for nitrate. This isn't related. It's specific to it is specific to nitrous oxide because it stops the absorption of thiamine, which is then relates to the neurological damage. So I'm not sure of why people may actually recommend other drugs to prevent that. I'm not really sure in a clinical setting. It's certainly at a very kind of community level, kind of peer-led harm reduction type of advice. The advice that's given is if you are using a lot of NANGs, to be aware of kind of the emergence of these neurological symptoms, and B, that it might be a good idea to take an over-the-counter, like a B12 supplement. But the types of people that come in with really severe neurological damage aren't just the occasional NANG user. Like most of the people who are coming in with really struggling with severe nerve damage are using hundreds.
So that's more your acute management rather than your kind of long-term sustainable kind of intervention.
Yes.
Okay.
Yeah.
I'm with you. Thank you.
Yeah, you're welcome.
Sorry, I was just chatting to my colleague. In relation to that, the Insight webinar that was probably, I don't know, 4 months ago or something. I can't remember the guy's name, but I've got it on my desktop or something saved. Covered Nang abuse really well. And I can send it around to the whole group because it was really fantastic. But my understanding was that you wouldn't use the B12, or that only works if the person stopped abusing the Nangs, because the problem is that it stops B12 uptake. So then if you administer the hydroxycobalamin, it doesn't do anything. But I'll send tomorrow, Monday, when I'm back in the office, I'll send around the webinar because it was really fantastic. Any other questions? No. All right. Can you join me all in thanking Rose, particularly given she's here on holiday? And thanks to everyone online for contributing to the questions. And we do have a lot of comments thanking Rose online. So thank you for those comments online.
He is going to thank me.
Yes, we are going out for dinner. So now is time for a 15-minute stretch break. We will be returning at 11:15 a.m. and the next session is setting up a nurse-led model of care with Jackie Richmond, who's down there. Nice to see you. And we'll see you all in 15 minutes. Thanks very much.